and then just the one that shows the PowerPoint screenshot only, not the desktop. You had it before, I think.
Right, I did. I pressed it and it didn't come up.
Okay.
All right, let me try to do it from here. Does that change anything?
No, I'm not seeing. You had it up the first time, but I think you had the desktop with the PowerPoint in it. You don't want the whole desktop screen with the PowerPoint. You just want the one with the screenshot of just the PowerPoint. And then you tap that one, and that will just show the PowerPoint.
Okay. Focus. So I'm pressing.
Pressing share.
I'm pressing the cloud presentation,
Okay.
and you see
The
when I press that, it disappears.
ah, which screen you in now? Um, okay.
Choose what app is.
Yeah, see, that's your whole desktop.
Yeah, this is my whole desktop.
No, you don't want that. You want just the PowerPoint.
So let me put the PowerPoint up.
The PowerPoint. Yes, that. You want just a screenshot of that. Yes. Okay. That's it.
All right, you see it? It's all.
Yes.
That's it.
That's
Okay.
it.
Okay. Okay. Good. Good. Sorry about that. No one ever accused me of being computer savvy.
That's fine. As
All right.
advanced should be
Okay. All right. So I should be able to move.
okay.
Everybody can see the screen.
Yes.
Okay. So good night, everybody. Pleasure to be here. Forgive my tardiness. My name is Dr. Parker. As Dr. Davis has illustrated, said before. Uh, so I'm a rheumatologist, and so rheumatology really is the study and the treatment and management of joint diseases, along with a number of other inflammatory disorders. So tonight we're actually going to talk about the most. I'm a rheumatologist. Is that, can everybody hear? We're going to talk about the most common inflammatory disorder, which is actually gout. And gout is an extremely painful condition and an extremely common condition in the country and in the world, indeed. So, what is gout? Gout is the intersection of an elevated blood uric acid along with uric acid crystal formation in the joints and soft tissue, and then ultimately the body's response to these uric acid crystals producing the painful syndrome that we know as gout and that people describe as gout. So, using the US figures, the gout prevalence continues to rise, and over the last half of the 20th century and certainly into the first half of the new century, the gout prevalence in the United States has been determined to be about 12% by age 80. So, what is uric acid? Uric acid is a breakdown product of DNA. Um, DNA is what our bodies contain within the nuclei. It is a building. It is the molecule that carries the body's information. And so the different primates don't develop gout because, interestingly enough, they possess an enzyme which breaks down the uric acid into a soluble component. This enzyme is called uricase. Now, we possess the genes for the enzyme. However, the gene for uricase is inactive in humans. And just like when you mix a cup of tea or a cup of coffee and you mix sugar into that tea or coffee, you will all note that at the end of it, by no matter how much you mix and no matter how much you stir, there's always a few crystals left at the bottom of the cup. And that's because every compound or every substance has a limit or a limited ability to be absorbed by the body. And uric acid has a very limited ability to be absorbed by the body. And so when there's too much uric acid in the body, you get a symptom, you get a state of hyperuricemia, where there's elevated uric acid. Now, this is fairly common. However, once the uric acid level exceeds about 6.8 milligrams per deciliter in the blood, it comes out of liquid form and starts to deposit as crystals in the body's tissue, just like that tissue, just like those crystals of sugar settle at the bottom of the cup. These crystals begin to settle throughout the body. And ultimately, as we will see later, they will lead to the clinical syndrome that we call gout. In men, the incidence of gout rises dramatically um, after puberty and is maintained through adulthood, whereas women are protected while they're menstruating and then usually have gout, will develop gout after menopause. The stages of gout. You have asymptomatic uricemia, hyperuricemia, where the uric acid is just elevated. Most patients with hyperuricemia will not develop gout. You will have some elevated uric acid. However, after the uric acid in the body begins to accumulate, a tipping point is reached, and you can develop acute intermittent gout, where you get the classic gout attack, usually in the big toe or a joint in the lower extremities of the body. And as we will discuss later, these attacks will become more and more frequent and more prolonged. And then you enter a state of advanced gout where you have joint destruction and you have the collections of the uric acid being visible on the body itself. So, gout is produced by an abnormal purine metabolism, purine being one of the proteins that's used to make DNA. And there's some people who have genetic abnormalities which lead to overproduction of purines. There are certain conditions where there's increased cell turnover, and by that we mean cells have their life cycle is increased, more cells are formed, and these cells die quickly. You see this in conditions like leukemia, lymphomas, certain types of anemia, we call them hemolytic anemias, psoriasis, a skin condition where there's a buildup of extra skin, and in patients who are being treated with chemotherapy, which causes the rapid destruction and breakdown of tumor cells, which then release their DNA, driving the uric acid up. So, diet and gout. That's dietary consumption of certain foods that actually promote the development of gout. These foods include seafood, red meats, organ meats, much to many people's surprise. I'm sure they may not realize, but high fructose products like sweet drinks increase the incidence of gout. alcohol consumption, and there are certain foods that actually reduce the rate of gout. In particular, low-fat dairy food reduces the rate of gout development. And the this is just a chart showing the rise of the rapid increase in the rate of the gout development circa 1950 with the development of the use of fructose as a sweetener. So gout is very much a lifestyle disease. Now these are American figures, but we essentially consume an American diet with a few modifications. I'm sure the conch and the crawfish don't help. So there are certain foods which you certainly want to avoid if you are a patient with gout, and these would include organ meats, which will be high in purine content. And so when making recommendations, we would tell them organ meats obviously are out, liver, kidneys. You want to limit your red meat and your seafood, particularly sardines and shellfish, and encourage white meat and low-fat dairy products. High fructose sugar, corn, and high fructose beverages, obviously, and alcohol, as we just discussed, will promote the development of gout and promote gout attacks in individuals who have gout. You want to reduce the serving size of the sugars you consume, and you know, in addition to the low-fat dairy, vegetables are to be encouraged in these patients. There are certain medications that are very common and that people can be on that actually can promote the development of gout or worsen gout if they develop it. This includes low dose aspirin and many common what we call water tablets or diuretics, which are in common use to control hypertension. So, how does gout present? Gout is a condition that has a very slow arc. Typically, one joint is affected first, usually or stereotypically the big toe. We call this condition podagra. And you get that classic swollen, tender toe. And gout, when it comes to pain, when it comes to inflammation, of all the inflammatory disorders, gout is the most painful. When a patient has gout, you can almost diagnose the patient by the patient's description of the pain, meaning you can't rub a sheet over that toe or that joint. You could barely stand to touch it. It is exquisitely painful. And that first gout attack usually will last for a few days up to a week and then resolve on its own. Attacks often occur during the night or early morning when the joint is coolest. The joint, as we said, is exquisitely warm, red, swollen, and tender. And there may be swelling and redness around the joint, resembling an infection or cellulitis. The early attacks can last anywhere from 3 to 10 days and resolve on their own if they're not treated. The joints most frequently attacked, essentially the big toe, the instep of the foot, the ankle, the heel, the knee, the wrist, the elbow, and the fingers. It moves its way from the distal extremities to the lower limbs to the upper limb. Why? Because gout it is believed that these joints are further away from the heart, so they all have a lower temperature, and so the uric acid is less soluble in the tissues in these tissues, and so the lower limb prevalence with early gout, and then gradually can spread to virtually any joint. Now, you can have gout occurring at sites on the skin adjacent or next to the elbow or in front of the knee. You can also develop deposits of gout in the skin. The most classic would be the olecranon bursa. You see people with, I'm sure everybody's seen individuals who have the swelling around the elbow. Most often, that's due to gout. There are other causes, but gout is the most common. So that would be soft tissue full of uric acid crystals. The same thing can happen in the tissue in front of the knee. Now, gout follows years of elevated uric acid. The first attack usually occurs in men in their 30s and 40s and postmenopausal women. And after that first attack, many patients don't receive or don't have another gout attack for another year or more. And so gout is a very slow condition in the beginning. It creeps. And so that can allow people not to, it tends to take people, confuse the patient in that they don't think that the disease is active when they're not feeling the pain. And all the while, one episode of pain, no matter how bad, isn't enough to drive a patient to make lifestyle changes or even to pursue medical advice. They simply take some over the counter pain medication and keep it pushing and allow the condition to progress by allowing the uric acid to accumulate throughout the body. So the crystals form in the body, and then things such as low temperature or precipitating factors such as trauma liberate the crystals from the tissue. And it is the detection of these crystals and triggers an immune response from the body. And the body essentially treats the crystals like an infection. The immune system sends the cells to target the crystals. The crystals then actually kill the cells that try to consume them. And it is this process that produces the painful syndrome of gout because the powerful enzymes and digestive and destructive enzymes contained within the cells designed to fight infection are then released as the cells are destroyed, and they have their powerful digestive and toxic and noxious effects on the tissues of the body, producing the pain, the swelling, and the redness. So we call collections of gout of uric acid tophus or tophi. And so we see here in the illustration, in the cartilage of the joint, there's the buildup of uric acid into microtophus. You cannot necessarily see. And as these grow and get bigger, they can rupture. And when they rupture or they grow to a certain size, the body begins to detect them. And most attacks will start when microtophi are destabilized and millions of crystals are released into the joint space, which then triggers a subsequent immune reaction. How do we diagnose gout? The ideal way to diagnose gout is to get some of the fluid from the joints and analyze the fluid to look for the cell count, how many cells are present in the fluid in a particular volume, and then you want to look for the presence of gout crystals, which have a certain appearance. So here is an arthroscopic view of the inside of a joint. And there you see the joint lining covered by uric acid crystals. And these uric acid crystals then rupture, as was illustrated before, and trigger the gout attack. Uric acid crystals look like chalky material both inside the body and outside the body. Now, this is the appearance of the uric acid crystals under what we call plane polarized light. When they are parallel to the light, they are yellow, and when they are opposite to the light direction, they are blue. And that needle shape and that yellow and blue coloration with respect to the direction or axis of the light helps us to diagnose gout when we analyze the fluid. And so here you see on the left the cells literally trying to consume the gout crystals. These cells have multiple nuclei and are called polymorphonuclear cells or white blood cells. They're a type of white blood cell. And as you can see, the gout crystals are often larger than the cells themselves. So these cells will try to swallow these crystals. The crystals will then lance straight through the cell, killing the cell. The cell bursts open, releasing its contents into the joint tissue or into the soft tissue. And its contents then burn up and destroy and digest the tissue, producing pain. So, how do we manage elevated uric acid? Before the patient actually develops the syndrome of gout, we want to counsel them on lifestyle modification. We don't tend to treat elevated uric acid unless it becomes very high, or the patient develops kidney stones, or the patient is found to have tophi, or collections of gout. The uric acid levels may go up and down, especially in a gout flare. They can even be normal. And so we want to keep the uric acid as low as possible because the longer the patient has an elevated uric acid, the higher the risk of him developing or her developing gout later on. So how do we treat the gout attacks and the gout flares? Well, here's an oldie but goodie. Colchicine, one of the oldest medicines in use. It is effective certainly within the first 36 hours after the onset of a gout attack. So you take 2 tablets of 1.2 milligrams, a total of 1.2 milligrams, followed by 1.6 milligram tablet an hour later. And if this is done within 36 hours of the onset or the beginning of the gout attack, it should help dramatically reduce the pain. Other alternatives would include medicines that we call NSAIDs. This is your Aleve, your Motrin, your indomethacin, the Selendac. These also treat inflammation. However, they can carry risks of ulceration of the stomach or kidney damage, so you must use them with discretion and use them as prescribed. Alternatives for patients with kidney or heart problems per se is to use prednisone or prednisolone for 5 to 10 days. Now, these steroids are anti-inflammatory and reduce the inflammatory response. You can also use intra-articular injection of of steroid to treat intra-articular gout manifestations if it's a single joint or large joints. So you can also use combination therapy with colchicine and NSAIDs if necessary, or all steroids and colchicine. Intra-articular steroids and other modalities can be used. Well, but you also want to be careful of the toxicity of the steroids and the non-steroids, in particular stomach toxicity and burning, heartburn. Usually after a patient has 10 or more years of intermittent gout, we consider them to have advanced gout. Now, the pain at this point can be persistent and is polyarticulate, means involves more than 3 joints. And diffuse joint involvement caused by by gout and by rheumatoid arthritis are indistinguishable. The way to distinguish them, one of the ways to distinguish them is the tophaceous deposits. So here's an example of tophi, white chalky substances in the ears, on the fingers. This is the uric acid building up under the soft tissue, coming out of a solution. And these cold distant from the heart places. And these tissues then come out of solution and they form solids. Again, another illustration of a tophi. Tophi, this white chalky substance, literally just depositing itself under the skin. And then you end up with the buildup of these chalky, large, bulky masses under the skin in critical areas, like the fingers. Now, at the level of the joint, gout causes rat bite erosions, where the erosions are outside the joint, and it looks like rats have bitten away or eaten away uh, at the skin, at the joint material and the joint lining. And you see these holes in the tissue and at the joints. The gout basically is just eroding the joint because what it ultimately wants to do is destroy the joint. To treat the gout, there's lifestyle and dietary modifications. Obviously, you want to eat a healthy diet, reduce the amount of high purine foods, reduce the amount of sugars and alcohol. However, patients who develop gout usually require lifetime treatment with medicines to lower the uric acid, like allopurinol, medicines to increase the uric acid excretion, or a form of the uricase we talked about, pegloticase, which can absorb and dissolve gout in a very miraculous, almost appearing way. Once the gout treatment is established, and once you're lowering the uric acid, you want to treat the patient with prophylaxis. That is to say, to give them a regular dose of colchicine so that the gout does not flare while you're getting them down to the goal uric acid. Once you get them down to the goal uric acid and the uric acid reaches below a certain threshold, our goal is 6, and in some patients 5. The uric acid simply won't come out of solution, and so you won't have the gout attacks. The pillars of gout treatment are lowering serum uric acid, prophylaxis with the colchicine and the nonsteroidals, and the steroids to prevent attacks in the future. And when the goal is achieved, you would actually stop taking the prophylaxis. So that is the end of the clinical discussion about gout. I'll be happy to take any questions at this point.
Thank you, Dr. Parker. That was a very comprehensive and interesting presentation. I do have one or two questions, not to trigger your brain, but just for some of our congregation that is here.
Yes, ma'am.
So, in your practice,
Yes, ma'am.
for the patients that you see that do have gout, is it more or females?
Is it more male than females? Well, I would say that
Is it more males you see or more females with the gouty flares or gouty presentations?
more males.
More males. Okay.
More males.
And specifically, any particular age group?
It's the middle age group, 40s to 60s.
40s to 60s.
Some notables in the 30s.
Okay. So not so much in the younger.
Not so much in the younger, no.
Okay. And now for our elderly population that's over the age of 65, just have one question. How do they know? Because I know you said it's the most common inflammatory arthritis.
Yes,
How
ma'am.
do they know the difference between whether they're actually having rheumatoid arthritis versus a gouty flare, or is that difficult?
Firstly, that's a very good question. I say that to say because the either or paradigm isn't stood up by the data. They actually have a positive correlation, and so patients can very well have both. That's
Oh,
usually not the case. That's usually not the case, however, but it can happen. So when it comes down to inflammatory arthritis, the gold standard is really to aspirate that joint, take some fluid out of that joint, and send it for analysis to determine whether or not there are any crystals present. If there are no crystals present in within the cells, then the gout isn't causing the pain. You can have crystals present, but if there are no intra-articular crystals, then the pain could be from inflammation of another kind. So it's the aspiration of the joint that is the gold standard. Now, it must be said that even though a big, bulky, chalky tophus can be recognized and be a distinguishing factor, in the absence of that white, chalky focus, and if there's just swelling, gout and rheumatoid arthritis can appear, at least advanced gout and rheumatoid arthritis can appear to be exactly the same.
okay. So that sounds like it's very difficult to distinguish. So,
Mm, Well, I would say not so. I would say once you do the due diligence, it's fairly easy.
okay,
And also, the history is a little different in most of the time as well. Rheumatoid arthritis usually develops insidiously as stiffness in the hands or feet, and then gradually it comes on. Gout attacks in their beginning are usually sudden, severe, and then they go away, and the patient is well between attacks. When it comes to rheumatoid patients, usually the patients are stiff all the time. If they don't have an outright pain, they're usually stiff. So it's a matter of history. It's a matter of um, examination, looking for tophi, looking at the ears and things like that. And so you can develop a lot of circumstantial evidence about the diagnosis to be fair. And then one of the other good things is that you can have other crystalline arthropathies. So the crystal analysis of the fluid can help to rule out things like pseudo gout.
okay. Thank you. I'm not sure if anybody else on the Zoom has any other questions.
Good night. Thank you, Dr. Parker, for the presentation. There are some open for questions now. Anybody have a question that they'd like to ask? I will begin.
As people talking, I can't hear.
You cannot hear me, Sister Javier?
I can hear you vaguely.
Good.
Let me turn up my volume.
Okay, yeah, it's very, 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 very faint.
Okay, I turned up my volume. Maybe it was too low. If you had a question, you can certainly ask it again.
Yes. First of all, I was trying to look. Is the gout is the gout? I was trying to find out if it's uh, anything to do with heredity. Is it
Ah,
heredity?
there are some genetic disorders, and there are some people who have a family history of gout. Yes, there's some. It can be such that it runs in families, but most times it's what you call sporadic, meaning that it just occurs.
Okay. Sister Adelma, could you come to the mic?
Good evening, Dr. Parker. I thought I heard you say, Adelma wrote in my name. I thought I heard you say that gout is something that you have, once you get it, you have it for the rest of your life. Is that what you're saying? The uric acid,
Um,
sorry.
well,
The increase in the uric acid.
what I said was for patients who require treatment, patients who develop the clinical syndrome of gout with elevated uric acid, those patients tend to, in the majority of cases, require medication to control the gout.
Thank you.
It tends to be chronic. To answer your question, it would tend to be chronic.
Produce the purine.
Say it again.
I was thinking in my mind, thought to control the gout by reducing those foods that you had mentioned that produce purine, and this results in the crystals that are formed.
Yeah. So that is certainly opening, certainly a first. But the significance of the purine is this: the true significance is that it can, when you limit the purines, yes, you can reduce the uric acid, and that will work for some people, but not for most. The reduction in the purine and um, the dietary restrictions are most effective. They're more effective for preventing gout flares than they are for preventing the onset of gout. You follow? They're more effective in the gout patient when he's trying, or he or she is trying to control their gout, than they are in necessarily stopping people from developing gout. I can't hear. Hello?
I'm not hearing it either.
So what I would want to say is I know that lifestyle is very important, and it's certainly, I don't want to discourage anybody from living a healthy lifestyle and trying to reduce their uric acid or employing that as a strategy. It is just that the majority of patients who have high uric acid won't develop gout, but those who do develop gout tend to need the medication to keep the uric acid under control. And yes, the dietary measures are helpful, but their impact is much greater in preventing attacks in patients with gout than actually preventing the onset of gout, because their effect on the absolute value of the uric acid is actually not that high. You're talking about 1 or 2 points.
I want to thank Dr. Parker so much for his presentation. And now we're gonna ask our health director to come now and do the presentation and the vote of thanks.
Good night, everybody. On behalf of the Health Ministry Department, I want to thank Dr. We do appreciate him taking his time out to do this presentation for us. And Sister Shirley, give this to you on his behalf. Thank you.
On behalf of Dr. Parker, I say thank you so much. This is a lot of fruits.
All right, once again, good night. We want to give thanks to everyone in the sanctuary and those on Zoom. We want to, on behalf of the health ministry with Elder Farquharson, myself, the women's department, women's ministry department, Sister Shirley Parker. We want to thank Dr. Parker, Dr. Pavia, Pastor Williams, Elder Hugh Sands, and the media department, and everybody who attended tonight. We just want to give you thanks and we appreciate the support. Thank you and have a good night.
In her mouth, like a marionette. You're burning me out, babe, like I'm on my last pack of cheap cigarettes. This place is a nightmare. Church for the rats.